Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight, our topic is the neuro-ophthalmology of multiple sclerosis, and we're very, very fortunate to have Dr. Len Messner as our expert speaker. He's the Vice President for Strategy and Institutional Advancement at the Illinois College of Optometry, and he has a rank of professor at ICO. He is the immediate past chair of the Neuro-Ophthalmic Disorders Special Interest Group at the American Academy of Optometry, and is currently a member of the steering committee of the Academy's Fellows Doing Research SIG. His predominant area of clinical practice and scholarly activity is the evaluation and management of people with neuro-ophthalmic disorders. In addition to his numerous other awards and honors, he is a 24-time recipient of the Teacher of the Year Award at Illinois College of Optometry. So with that, it's our great privilege and pleasure to bring to you Dr. Len Messner to share his expertise in what's going to be a very high-level presentation. So with that, Len, please take over.
Well, thank you, Joe, for that very warm introduction. Thanks to you and Greg for inviting me. And of course, thanks to Vanessa for all her behind-the-scenes magic. There we go. I would like to mention a good friend, Laura Balser, who approached me several years ago with the suggestion that we put this talk together for the viewing pleasure of various optometric and ophthalmologic audiences. And these are my disclosures. And the key points of this evening's discussion are as follows. I'm going to begin by talking a little bit about the epidemiologic profile and the evolving diagnostic criteria for multiple sclerosis. We're going to talk about the pathogenesis and the classification of multiple sclerosis, and specifically how this ties in with the emerging drug therapy. And then we're going to spend a lot of time talking about the neuro-ophthalmic manifestations of MS, both afferent system disease as well as efferent system disease. And then I'm going to finish by talking a little bit about structural biomarkers of disease activity, notably OCT evaluation among individuals with multiple sclerosis. So with that, let's talk a little bit about the epidemiology of MS. And as many of you know, this is a condition that is largely, that is found with a greater preponderance among women versus men. The average age of onset is between 20 and 40 years, although that's quite, although there are significant outliers on both sides. There may be genetic risk factors that go along with MS. And interestingly, for many years, it's been known that where an individual lives plays a significant role in the development of MS, particularly early in life. Now, this is a nice study that was published last year in neurology, specifically looking at the prevalence of MS as a function of latitude. And specifically, the further you get from the equator, the greater the likelihood of developing MS. And this is thought to be, at least in part, due to the increase in UVB and the activation and production of vitamin D, vitamin D3 among individuals that are closer to the equator, and less vitamin D activation the further you get away from the equator. So that really goes in alignment with what some postulate as a potential neuroprotective element to vitamin D supplementation with MS. The 2010 McDonald criteria, revised McDonald criteria for multiple sclerosis, very simply stated that MS can be defined as two or more separate areas within the central nervous system of demyelinating activity that are separated by both time and space, with the caveat that none of this is related to another disease process of the central nervous system. Now, in 2017, the McDonald criteria was modified to what is currently in use today, and that is a resurrection of the identification of oligoclonal bands within the cerebrospinal fluid of individuals with a clinically isolated syndrome, such as optic neuritis or a brainstem lesion, regardless of dissemination in time. It also now includes cortical lesion in the in the criteria for MS. But most importantly is that both symptomatic and asymptomatic MRI lesions that are separated by both time and space qualify for a diagnosis of MS. And this is going to make a little bit more sense as I go through some cases a little bit later. But to a large extent, the driving force behind the modified McDonald criteria was to push for earlier diagnosis, because nowhere is it truer in medicine that the adage treat early, treat often applies as much as probably it does with multiple sclerosis. Now, while all of this is good, unfortunately, there remains no pure ocular domain that falls within the McDonald diagnostic criteria, but that may be changing over time. When you think about the pathogenesis of MS, it's largely an inflammatory event within the central nervous system that leads to demyelinization. And this, going back and forth, these episodes of inflammation followed by demyelinization, essentially is what constitutes relapsing remitting multiple sclerosis, which is true of most of the population. But at some point in time, these individuals cross they lose enough axons that they no longer improve significantly and rather deteriorate progressively over time. And that's secondary progressive multiple sclerosis, which is largely defined as a combination of axonal destruction and then fibroglial remodeling of the central nervous system. So when we think about what happens in the central nervous system, and specifically the inflammatory events, this can be divided into involvement of T cells and B cells. Now, the T cell pathway was first to be understood and reported on well over 10 years ago. And it goes something like this, that an individual is exposed to some type of a trigger. Largely, that is now believed to be a virus. And that the virus, the protein code of the virus, to a large extent mimics the protein code of myelin, at least for the host individual. And then from here, T cells that are outside the central nervous system within regional lymph nodes become primed. And then from here, they cross the blood-brain barrier via integrin transport proteins to enter into the central nervous system and attack myelin, attack the myelin sheaths of axons. And this in turn results in a degradation of the axons and the kicking up, if you will, of more myelin-related antigenic proteins that then cross back into the peripheral nervous system, outside the central nervous system, and allows for a replication of this T cell priming and enter into the central nervous system. So that's the T cell path. What about B cells? B cells are a little bit newer to the equation. B cells are very important in the pathogenesis of MS. They regulate cytokines. They're exquisitely responsible for presenting in the co-stimulation of antigens. And as we know, B cells are predominantly responsible for the production of antibodies. So now there is this dual mode of both B cell and T cell activity that is not only related to the pathogenesis of MS, but really cuts to the core of disease-modifying therapy for this disease. So that's essentially what this rather busy slide is showing. On the very left-hand side, you can see everything that's going on outside the central nervous system, and specifically opportunities for pharmacotherapy to block or blunt these pathways. Then you have the crossover, blood-brain barrier of these inflammatory cells to enter into the central nervous system, and of course, create this cascading process. And here again, there are opportunities for disease-modifying agents to blunt or quell this process. So in other words, disease-modifying therapy works in a few ways. It suppresses the inflammation, both B cell and T cell activity. It inhibits the transport of lymphocytes into the central nervous system, and then it modulates the B and T cell activity. Now, that's all good stuff, but and it's great that there are all of these disease-modifying agents that largely fall into the category of monoclonal antibodies, and they work very, very well. But the problem with monoclonal antibodies as a general class of drug is that they suppress the immune system. And there's a particular disease that goes along with immune suppression within the central nervous system. And that's a potentially lethal condition called progressive multifocal leukoencephalopathy, or PML. And this is triggered by a JC virus. So that's why you hear from your patients that they have been tested for the presence of a JC virus before being treated with one of a host of disease-modifying agents that fall into the monoclonal antibody categories, and then they are tested periodically over time. So let's talk a little bit about classes of MS. The two most common are what I've put on the top here in yellow. Relapsing remitting, which is about 85% of all individuals with MS, followed by secondary progressive. Primary progressive MS is maybe about 5 to 10%, and progressive relapsing is a variant of primary progressive that is less than 5 to 10%. But what we want to do is focus on the most common types of MS, and that is relapsing remitting disease along with secondary progressive. Now, what I've shown you in this, what I've shown you graphically here is the characteristic relapse remit that goes along with relapsing remitting disease. But as I mentioned before, at some point in time, many, if not most of these individuals, and it's estimated that roughly 2/3 of individuals are going to cross that threshold where they lose just enough axons where they no longer show significant improvement or significant remission of their signs and symptoms. And from here, they show progression of disease burden and disease activity over time. And that is what is termed secondary progressive MS. Now, while this is the clinical course of the disease, if you look at effectively what is going on within the central nervous system, I've drawn that for you here with this yellow line. And that is that even with relapsing remitting disease, when they're feeling good, when they are in periods of remission, the disease is still moving forward and less adequately controlled through pharmacotherapy. And that's why, again, it gets back to this analogy or the saying, if you will, of treat early, treat often. This is a non-curable disease. But you know what? There are many things that we see, particularly within optometric practice, that are not curable, but they're controllable. Glaucoma, of course, is one of them. If someone were to come up with a cure for dying, all of our glaucoma patients would go blind from their disease. But the good news is eventually people die, so that effectively the disease outlives the patient. And that's exactly the goal of therapy with multiple sclerosis, is until there may come a time for a cure, it's really a matter of shifting this disease curve further to the right so that individuals live a long, productive life. So maybe this is a good time to begin with our first polling question, which is, what is the most common type of multiple sclerosis? A, relapsing remitting; B, secondary progressive; C, primary progressive; and D, progressive relapsing. So we'll give everybody a minute to make their choices.
And Lynn, as they're making their choice, I'm looking at the list here of all the people that are on, and a lot of them are familiar faces and familiar names, and and they've heard me hammer over the last 18 months, 24 months, understanding the immune system, understanding that we have an innate immune system, an adaptive immune system, and you have to now understand the complement system, because now Iveric and Apellis have their C3 and C5 inhibitors for macular degeneration that complement. And here you are talking MS, talking about that adaptive B cell, T cell kind of dysfunction that's out there. So, and then where your medications will kind of target that. So again, I always harp, it's, you kind of have to learn that immune system, learn that innate, learn that adaptive complement, and then that will help you with disease processes and pharmacotherapies that are out there.
Yeah, that's really well said, Greg, because there's, this, of course, is an autoimmune disease, and there's so many of these that we encounter on a daily basis. All right, great. Well, the majority have got the answer right. Relapsing remitting is indeed the most common type of multiple sclerosis. So let's move on now and talk about the neuro-ophthalmic manifestations of MS. And specifically, we're going to talk about three things: optic neuritis, the brainstem motility disorders, notably the internuclear ophthalmoplegia, and then finally, nystagmus. Let's begin with optic neuritis. Now, there are various types of optic neuritis. By far, the most common is what is termed demyelinating or primary demyelinating optic neuritis. And this is what we refer to as optic neuritis that is specifically related to multiple sclerosis. And this is about 90% of everyone that you're going to see with optic neuritis. But within the other 10%, the two most common diseases that make up that additional 10% are neuromyelitis optica spectrum disorder, or NMOSD, and then the new kid on the block, myelin oligodendrocyte glycoprotein antibody-associated disease, also known as MOGAD. So let's begin by talking about demyelinating optic neuritis, which can be thought of as a focal, inflammatory, and demyelinating event of the optic nerve that may be idiopathic as a clinically isolated syndrome and localized to the optic nerve, or may be or become associated with multiple sclerosis. And as I said before, overwhelmingly, this is the most common type of optic neuritis that we see. You can classify demyelinating optic neuritis into two categories: anterior optic neuritis, also termed papillitis, and the more common of the two being retrobulbar optic neuritis. Now, this is an example of retrobulbar optic neuritis where the patient presents, the vision is reduced. Typically, there's pain on eye movement. There's an afferent pupillary defect, but the optic nerve looks essentially normal. And this is about 2/3 of individuals that we see with optic neuritis. And the reason that, at least from the get-go, the optic nerve looks normal is because the demyelinating plaque is occurring retro to the lamina cribrosa, oftentimes near the orbital apex. Now compare that, if you will, to this, which is anterior optic neuritis. And this is about 1/3 of all individuals with demyelinating optic neuritis. Once again, acute or subacute vision loss, some pain on eye movement, but an afferent pupillary defect. But the key thing is the absence of blood. You're not allowed to have blood on the optic nerve in order to qualify as having demyelinating optic neuritis. If there's a hemorrhagic papillopathy, it's something else that's going on. It could be ischemic optic neuropathy. It could be one of the other types of optic neuritis that I'm going to talk about later, notably MOGAD, but it's not demyelinating optic neuritis. So
Actually, Len, can you go back just 1 second, please?
sure.
I recognize this photo because you used it at the academy. But at 12 o'clock, just point out that's not a hemorrhage. That is a vessel.
Absolutely. I think what you're referring to, Joe, is this thing right here. Yep, that's a retinal blood vessel. And what you can see is that it's actually obscured, and the reason that it's obscured is because of the circumferential optic disc swelling. Great point. So a lot of what we know related to the features, the clinical features of optic neuritis, were reported over 30 years ago through the optic neuritis treatment trial. And overwhelmingly, these individuals do present with some form of abrupt vision loss. Visual acuity is quite variable. It may be negligible visual impairment. It may be profound visual impairment. From ONTT, the average vision loss at baseline was 20/60. These individuals always have an afferent pupillary defect, and they always have dyschromatopsia, and oftentimes the dyschromatopsia is worse than their vision. What I specifically mean by that is that these people have problems discriminating color. Now, there are a host of optic neuropathies that also make it difficult to discriminate color, such as ischemic optic neuropathy. But with ischemic optic neuropathy, the dyschromatopsia typically parallels the level of visual acuity loss. So in other words, as the vision gets worse, the ability to discriminate color gets worse. That is not true with demyelinating optic neuritis. With optic neuritis, it's not unusual at all to have minimal involvement of visual acuity, but to see extensive dyschromatopsia where they're just not able to appreciate any of the color plates that you throw at them, or when you ask them to compare between the two eyes, the red cap of your Madrayacil bottle, it's extraordinarily washed out in the diseased eye, and it looks fairly bright in the normal eye. Now, going along with that is decreased brightness. These individuals, this is a conduction deficit. It's a demyelinating event of the optic nerve that is reducing conduction back to the visual centers within the brain. So with that, even if the visual acuity is not significantly affected, these individuals they notice that things are not as bright in the diseased eye. And as we like to tell our students and residents, one of the easy ways of checking for this is to simply perform indirect ophthalmoscopy. Instead of these individuals fighting you because the lights are too bright, patients with optic neuritis, they pretty much just sit back and take it because their brightness is so reduced. Now, as a general rule of thumb, the vision is going to get about as bad as it's going to be with demyelinating optic neuritis at about 2 weeks. And from there, well over 90% are going to recover back to normal or near normal vision, albeit with some sustained decrement of color or brightness. So it's important to tell your patients that is that, look, there's an excellent chance that your vision is going to get significantly better. But if you look for it, there's still going to be some washout of color and some loss of brightness. And then finally, pain, or what is probably better described as discomfort, and specifically discomfort that's exacerbated when you move your eyes back and forth. And the reason for that is very simply because you've got a demyelinating event within the optic nerve that is inflaming the optic nerve sheath, which is a direct reflection of the meninges, highly innervated, that is directly communicating with the sheaths of the extraocular muscles. So as you move the eyes back and forth, that's going to tug on this meningeal covering of the optic nerve, which is going to be responsible for the pain. So let's take a look at a case. Here's a 29-year-old woman who comes in with acute vision loss in her right eye. She reports that everything looks dark and dim. She's got a dull pain behind her right eye that seems to get worse when she moves her eyes. She's got an afferent pupillary defect in the right eye. Vision is significantly reduced in the right eye at 20/400 and 20/20 in the left. Looking at her optic nerve, you can see that there is just a little bit of swelling going pretty much all around the optic nerve. But as I said before, no evidence of blood. Can't have blood in the setting of demyelinating optic neuritis. And looking at the fellow eye, what we can see is pretty much a normal appearance of the optic nerve. Now, looking at the visual field, what you can see is that in the affected eye, there is a fairly dense central or centrocecal scotoma with a mean deviation of about -19, close to -20 decibels. But over a period of 3 months, what you can see is that this individual's visual acuity has improved dramatically, as well as her visual field. And again, this is very, very common with demyelinating optic neuritis. If the vision and the visual fields are not getting better, you need to rethink the diagnosis. So what about visual field defects? Well, I would say when Joe and Greg and I were in training, at least when I was in training, because I am older than my esteemed colleagues, but we were taught that the most common visual field defect with optic neuritis was a central or centrocecal defect. But much of that was based upon, shall we say, old forms of perimetry, Goldmann visual fields. And by and large, we don't use Goldmann visual fields that much any longer. But with automated threshold perimetry, what you can see are the results from the optic neuritis treatment trials showing that the most common visual field defect is a more or less generalized or diffuse form of visual field loss, and that localized field defects, specifically if you look at the central or centrocecal defects, only affect about 8% of individuals with optic neuritis. So that's what's going on in the affected eye. What about the non-affected eye? Well, here again, we can see that visual field defects are pretty common, which is another reason why you always test both eyes as it relates to perimetry. Now let's take a look at some cases to bring this point home. Here's a 30-year-old woman complaining of reduced vision in her left eye of about 5 days, and she reports to you that the vision is dark and dim and it's getting worse over time. In the right eye, her optic nerve looks normal, visual acuity is 20/20, and in the left eye, you can see that the optic nerve looks normal, but vision is now reduced to 20/80. She has pain on eye movement, and she also has an afferent pupillary defect. So this is the typical presentation of retrobulbar optic neuritis. Now, looking at her visual fields, predictably in the left eye, left is on the left, right is on the right. Oops. What you can see here is this generalized form of visual field depression. But in the right eye, where her vision is 20/20, you can see that it's not entirely normal. It's not entirely pristine. She's got a few misses here involving the nasal portion of the visual field. So my point is that these subtle fellow eye abnormalities show up in about 50% of individuals with optic neuritis. Here's a 25-year-old woman, decreased vision in her right eye. It's been there for about a week. It's getting worse. 20/400 vision, afferent pupillary defect, pain on eye movement. And here you can see that she has this non-hemorrhagic edematous appearance to her optic nerve. Looking at the fellow eye, entirely normal appearance to the optic nerve with 20/20 vision. But look at her visual fields. Predictably, she has something of a generalized visual field loss on the right side, but on the left, you can see, let me go back here one more time. Yeah, but on the left where she has 20/20 vision, you can see that she has these indiscriminate areas of visual field loss as well. So once again, fellow eye visual field abnormalities, roughly 50% in the setting of demyelinating optic neuritis. And looking at her brain, you can see this is a T2 flare image. It's an axial cut just above the lateral ventricles. And what we can see is that within the paraventricular white matter, there are multiple high signal lesions that are ovoid in appearance that are somewhat perpendicular to the lateral ventricles that are typical of multiple sclerosis. So let's talk a little bit about the MRI characteristics of MS. First of all patients with optic neuritis require an MRI. What I do is I get an MRI of the brain and orbits with and without contrast. Now, T1 weighted imaging is very, very good for looking at the structural integrity of the brain. It's very, well, let me rephrase that. It's good at looking at the anatomical constructs of brain parenchyma. With multiple sclerosis, the demyelinating plaques typically look like normal brain. But with gadolinium as the contrast agent, there is this enhancement of these lesions, and I'm going to show you an example of that in just a moment. Now, T2 weighted imaging and flare imaging, these are sequencing elements that essentially look for demyelinating plaques. If they're there, they'll show up on both T2 as well as flare, but they don't necessarily provide information as it relates to the chronicity of the disease process. That's where gadolinium comes into play, because only acute or subacute lesions will enhance with gadolinium. If they've been around for, say, 6 weeks or longer, they lose that ability to enhance. Now, here's a 42-year-old woman who comes in to see you, complaining of recent onset vision loss in her left eye. Visual acuity is 20/20 in the right eye, 20/60 in the left. She has an afferent pupillary defect in the left eye, and she complains of some degree of pain behind the left eye when she moves her eyes around. Looking at her fundi, normal appearance to the optic nerve on the right side, normal appearance to the optic nerve on the left side where her vision is reduced. These are her visual fields, and what you can see, she's got a little bit of a central defect just below fixation in the left eye. In this case, actually, her visual field in the right eye is entirely normal. But here are her visual pathways. Now, this is a T1 weighted image through the optic nerves, and specifically through the prechiasmal segments of the optic nerves. And this is a coronal cut that is taken with gadolinium as the contrast agent. So beginning with the right side, right is on the left, left is on the right. It's just as though you're looking directly at the patient. So here you can see on the right side of this patient's brain, this is the right optic nerve. It looks a little bit gray, pretty much the same color, same appearance as normal brain parenchyma. But on the left side, what you can see is this bright or enhanced appearance to the optic nerve on the left side. Now, this is near the orbital apex. And this focal plaque, this focal area of inflammation, is this individual's demyelinating event of her optic nerve. This is responsible for her vision problem. Here's a 56-year-old man. He comes in to see you complaining of vision loss in his right eye of about 3 days duration. Visual acuity in the right eye is 20/40. In the left eye, it's 20/20. He's got an afferent pupillary defect in the right eye, and he's got some discomfort or pain on eye movement behind the right eye. Looking at his optic nerves, other than a little bit of a myopic crescent, pretty much normal appearance to the optic nerve in the right eye, and similarly in the left eye, with the exception of a myopic crescent, pretty much normal appearance of the optic nerve. Now, looking at his visual fields, what you can see is that in the right eye, he has this rather characteristic diffuse visual field defect on the right side. And on the left side, where he has 20/20 vision, he's got a few subclinical areas of visual field involvement or visual field depression. But looking at his optic nerves, and this is a coronal cut through the orbits, specifically through the optic nerves. And what I'm pointing to here with the arrow is the enhanced appearance of the optic nerve on the right side near the orbital apex. So enhancing optic nerve on the right, essentially normal appearing optic nerve on the left. Now, these other things that are enhancing within the orbit, these are just the recti muscles, or these are just the extraocular muscles. It's entirely normal for recti muscles to enhance with gadolinium. But the rest of the story for this individual goes something like this. This is the rest of his brain. What you can see on the left side, this is a flare. This is a T2-weighted flare image through the lateral ventricles. And you can see that he has multiple high signal lesions. Some of these are subcortical. Many of these are within the paraventricular white matter. But on the right side is the same level. This is a T1-weighted image, but with gadolinium. And what you can see is that not all of the lesions that are showing up on flare are necessarily enhancing with gadolinium. What that means is that some of these lesions are acute or subacute, and those that are not enhancing are chronic. Going back to the revised McDonald criteria of MS, these are demyelinating events within the central nervous system as identified by MRI that are separated by both time and space. By definition, not only does this individual have optic neuritis, but he also has multiple sclerosis. So what can we say about the myelinating optic neuritis? Well, from the optic neuritis treatment trial, at 15 years, 50% of individuals, all comers, will develop multiple sclerosis. But that conversion rate to MS is much, much lower for individuals with a normal brain at baseline as compared to individuals with an abnormal brain, 2 or more demyelinating lesions within the brain at the time of their optic neuritis. So what that tells us is that an abnormal brain in the setting of optic neuritis is at least a very, very strong indicator of the development of MS, if not showing that the individual already does have multiple sclerosis. So to sum it up, demyelinating optic neuritis, I can do so in the following way. Number one, excellent visual prognosis. We know that at 15 years, over 90% of these individuals, regardless of how they've been treated, or even if they've not been treated at all, will recover vision to 20, 40, or better. And if they don't, you need to rethink the diagnosis. We know that optic neuritis in the setting of an abnormal brain at baseline is a strong indicator for these individuals to convert to MS. And to take that one step further, what we now know is that an abnormal brain in the setting of optic neuritis with both enhancing and non-enhancing brain lesions, this is multiple sclerosis, and these individuals need to be treated appropriately. So that's demyelinating optic neuritis. That's 90% of everything that you're going to see. What about the other 10%?
Len, before you move on, I wanna go back to your last case, if you don't mind.
Sure.
If you can just back up a little bit, what I found kind of interesting and just something for food for thought. If you can go to his profile, you said it was a 56-year-old male, correct?
Yeah.
Okay. Now, I am completely on board. If this were a 24-year-old female, makes all the sense in the world. 56 male is a little bit atypical. Would you agree?
Absolutely. Absolutely.
So what I would also suggest, my approach would be what you're doing, but I'd also consider in my differential diagnosis posterior ischemic optic neuropathy and the possibility of GCA. And I'd want to probably get the serology myself. What are your thoughts on that, Len?
I think that's entirely reasonable, Joe. He may be a little bit young for giant cell, but you know what? There are outliers in both directions. This just happens to be an outlier for multiple sclerosis, but you're 100% correct. It's not to say that it could not be an outlier for giant cell as well. Completely agree. All right, so getting back to the other 10%, about 90% of that other 10% are going to fall into this category. Neuromyelitis optica spectrum disease, what used to be called Devick's disease, and myelin oligodendrocyte glycoprotein MOG, antibody-associated disease. Let's begin by talking about NMO. This, just as is true with demyelinating optic neuritis, is more common among women as opposed to men. But they're slightly older than the typical profile of demyelinating optic neuritis. I said before that most individuals with demyelinating optic neuritis, they're usually going to present within their 20s or within their early to mid 30s. With NMO, they tend to be older, such as presenting in late 30s and into the 40s. Another differentiator is that NMO involves both gray and white matter, and the reason for that is because of the underlying pathology. The serum identifier, or the biomarker for NMO, is the presence of antibodies directed against aquaporin 4 channels within the central nervous system. Now, if an individual is producing these antibodies and they're attacking these channels within the central nervous system, it specifically destroys the astrocytes, and it destroys them quite violently. This leads to secondary destruction of oligodendrocytes, and oligodendrocytes, of course, are responsible for the production of myelin. So that leads to the demyelinization and ultimately the cell death. So you do get loss of myelin with NMO, but it's a secondary complication, not the primary portion, not the primary focus of the disease. So what about optic neuritis of NMO? Well, overwhelmingly, optic neuritis associated with MS, it's going to be one eye, or at least one eye at a time. With NMO, there's a significant number of these individuals that will present with bilateral simultaneous ocular involvement. In addition to the optic nerve involvement, many of these individuals, typically within a matter of weeks, will develop transverse myelitis, so that they develop a weakness of their lower extremities, sometimes their upper extremities, but usually their lower extremities. They can have back pain, they can have incontinence. All of that goes along with their transverse myelitis, which is an inflammation of their spinal cord. But the kicker is what I've underlined for you here, is that over 90% of these individuals from the get-go are going to test positive for aquaporin 4 IgG, or antibodies that are directed against the aquaporin 4 channels within the central nervous system. And these largely are found within the visual pathways, notably the optic nerve, prechiasmal segments of the optic nerves, to a certain extent the chiasm, and they're found within the brainstem, up to the basal ganglia and down to through the brainstem, involving the spinal cord. Now, because the brainstem is commonly involved with NMO, acute brainstem syndromes are commonplace with this disease. And one of the things that we ask our patients about that present with optic neuritis on a regular basis to try to pull out NMO is, have you recently begun to notice uncontrollable hiccups, nausea, or vomiting? And along with that, do you also have, or are you also becoming progressively somnolent or suffering from narcolepsy? These are strongly associated with NMO, yet don't see these guys with MS. So what about neuroimaging? Well, with the spinal cord, by definition, transverse myelitis can be thought of as 3 or more contiguous vertebral segments of enhancement that are showing up on MRI. But specifically what I want to talk about are the ocular findings, or the optic nerve findings. And the characteristic findings of NMO is bilateral involvement with something of a V pattern type of enhancement back to and involving the optic chiasm. Now, this is a case that is supplied courtesy of Chris Borgman, showing this very classic V pattern bilateral enhancement of the optic nerves coming back to the orbital apex, beyond the apex, to involve the chiasm. So that V pattern enhancement involving the chiasm is highly pathognomonic of NMO. So what's the treatment for NMO? Well, upfront, IV corticosteroids. I want to preface this by saying that this can be a devastating disease. I said earlier that 90% of individuals with demyelinating optic neuritis, that regardless of what you do for them, regardless of what anybody does for them, their vision is going to improve to a normal or near normal level. That's completely not true with NMO. Fewer than 50% of these individuals show any significant improvement of vision. So that's why it's a matter of treating them aggressively up front with IV steroids and then switching them over to maintenance therapy. And maintenance therapy largely falls within the domain of one of a variety of immunosuppressive agents. We see that mycophenolate or Cellcept. Many patients that I see historically have done pretty well with Cellcept as their immunosuppressive agent. There's a new drug that's available through infusion therapy. That's Uplinza, which isn't given by infusion, which also has a very good safety profile, as well as it seems to work very, very well in preventing these relapses. But the point I want to make to you is that the relapse of optic neuritis with demyelinating optic neuritis, that we associate with MS, is problematic, but it's not a disaster. The relapse with NMO is a disaster. Many of these individuals do not recover vision at all. So it's all about preventing the relapses in NMO, and specifically with some form of immunosuppressive therapy. Before I move on, these individuals do not respond to the disease-modifying agents that we previously paid lip service to with multiple sclerosis. Now, let's talk about the newest form of optic neuritis, and that's MOG, antibody-associated disease. This shows no strong predilection in women versus men. It can be unilateral or bilateral. In the old literature, there was a condition called chronic relapsing inflammatory optic neuropathy, or CRION. And now that we have a chance to look backwards, we realize that many of those individuals that were described as having CRION probably had MOG antibody-associated optic neuritis. Now, I said before that you're not allowed to have blood on the nerve with demyelinating optic neuritis. But with MOGAD, you can have a hemorrhagic papillopathy. Oftentimes you get severe optic disc swelling, sometimes with blood in the setting of MOGAD. Particularly with kids that develop this disease, their optic neuritis may be preceded by something called acute disseminated encephalomyelitis, where they have this diffuse inflammation and demyelinization of the central nervous system that leads to lethargy, loss of normal cognition, headaches, fevers. But ultimately, these kids, with or without steroids, they get better on their own, and they only have one attack. But in many kids with ADEMS, the next, and if it's caused by MOGAD, this will then be followed by optic neuritis. But just as there is a strong serum biomarker for NMO, same thing holds true for MOG. And that biomarker is myelin oligodendrocyte glycoprotein IgG, or MOG IgG. Neuroimaging of MOG, typically their brains are normal, but their optic nerves are not. But instead of having a focal demyelinating plaque, you get this longitudinal enhancement. Now, one of the differentiating factors sometimes with MOGAD versus NMO is that the enhancement of the optic nerve with MOGAD typically stops at the orbital apex. It doesn't go back to involve the chiasm, as is true with many cases of NMO. Treatment, upfront steroids, IV steroids, and these individuals respond beautifully. That's something of a diagnostic indicator. People that have demyelinating optic neuritis, usually within 3 to 5 days, they're noticing some improvement of their vision. With MOG, typically within 24 hours, their vision is back to normal or near normal. So very, very rapid response to IV steroids, strong indication that this is MOG. Now, as it relates to maintenance therapy, it's less well established with MOG as compared to NMO. And the reason for that is because 50% of individuals with MOG, they're going to develop optic neuritis, their vision is going to get better, and they're done. Unfortunately, another 50% are going to relapse. And every time they relapse, they're losing more and more axons. And that's where immunosuppressive therapy, as well as IVIG, may play a role in the form of maintenance for individuals with MOGAD in order to preserve optic nerve integrity. Now, this is a 51-year-old woman who presented initially with her first attack of optic neuritis at about the age of 43, 44. And she had vision loss in her right eye with pain, counting fingers at 2 feet. This was in about 2013 with an afferent pupillary defect, disc edema, MRI of the brain read as normal, and then her vision recovered spontaneously to 2020 within several months. But she comes back 7 years later. Now she has acute painful vision loss in her left eye, 20/20 vision in her right eye, so you can see the vision recovered in the right eye. But now her vision is down in the left eye, 20/60. She's got an afferent pupillary defect. This is wrong. This should be in the left eye, not the right eye. Looking at her optic nerve, she's got a little bit of pallor in the right eye. That's her prior optic neuritis. But look at what's going on in the left eye. You can see that she's got edematous optic nerve and maybe a little bit of superficial hemorrhage. So this is her new optic neuritis in the left eye. Here you can see the edematous appearance of the optic nerve on OCT. And here you can see, particularly on the right side, this enhancement of her right optic nerve back to the orbital apex. That's typical of individuals with MOGAD. Now, over the past several years, she's had multiple recurrences, both in her right as well as left eyes, all of which have responded well to IV steroids. But the problem is, look at what's happening below. You can see that her optic nerves are really thinning down to next to nothing. So her last relapse was in March of 2022. At that point, she was started on mycophenolate, and I just saw her a couple of weeks ago, and she's remained relapse-free for about the past year and a half. So that's MOGAD. So question number 2, what is the most common type of optic neuritis? Is it demyelinating Is it NMOSD or NMO? Or is it C, MOGAD?
No questions have rolled in here, Len. Monitoring
the
the
audience
chat
is
box for you.
very silent.
Okay.
We'll be done here in a second. I'm just waiting for those numbers to get up to make it synchronous.
All right. Practically everybody got it right, so we're well on our way. Just want to say a few things about kids and optic neuritis. As a general rule of thumb, kids, and by kids I'm saying individuals that are pre-adolescent, they can develop optic neuritis, and usually their vision is significantly worse than adults. About 90% of individuals, of kids, have vision loss of 2200 or worse, versus only about 46% with adults. Optic disc swelling is more common in kids. Pain is less common. And when you look at the gender predilection, prepubescent versus postpubescent, prepubescent, 1-to-1, females and males equally affected. But postpubescence, it begins to look more like an adult presentation, more skewed toward women than men. Talk about laterality. Under age 10, bilateral optic neuritis, about 70% of the time. Over age 10, 70% unilateral. If we think about increased risk of MS, it's true that white matter lesions at baseline are a significant predictor or indicator or risk indicator for the development of MS, but particularly among kids that are older as opposed to pre-age of 10. So what you can basically see is that as kids mature, their risk of developing optic neuritis and their presentation of optic neuritis begins to look more and more like that we just described with adults. Here's a 15-year-old girl, reduced vision in her left eye, pain on eye movement on the left side, afferent pupillary defect, normal medical history, normal neurologic exam, vision's reduced to 20/40. You can see that the optic nerve on the left side is a little bit swollen, pretty normal on the right. You can see that she's got a little bit of disc swelling on the left side as evidenced by increase in nerve fiber layer thickness. Her ganglion cell maps are normal. Now that's going to change. Over time, the nerve fiber layer is going to thin down and her ganglion cell layer is going to thin down as well, both in the left eye. Looking at her visual fields, a little bit of a paracentral defect in the left eye. And then here is her demyelinating plaque of the optic nerve on the left side. Here you can see the enhancing longitudinal segment of her optic nerve, but instead of the longitudinal enhancement that I described before, you can see that this is more focal, right at the orbital apex. And the rest of her brain is normal. I saw this young woman about 5 or 6 years ago. Her vision recovered normally, and at least of this presentation, she has not developed multiple sclerosis. So what about the optic neuritis workup now? Well, I already said that all these individuals deserve an MRI of the brain and orbits with and without contrast. But in addition to that, right up front, it's important to get IgG titers for both aquaporin 4 as well as MOG. And I'm going to take that one step further. It used to be that we would order these studies on an outpatient basis. I send these patients in to be worked up now through the emergency department because it's important to get this stuff done quickly. Everybody now pretty much gets steroids with optic neuritis. The key thing is if they have NMO, you want to identify that as soon as possible so that they can be switched over to maintenance therapy. On the flip side, if they have other brain lesions, that are suggestive of MS, it's important that that be recognized and that these individuals be treated as quickly as possible. So all three right up front, MRI of the brain and orbits with and without contrast, as well as aquaporin 4 IgG, as well as MOG IgG. Now with that, I want to switch over and talk about efferent system disease, and specifically a discussion of the intranuclear ophthalmic lesions. Now, this is one of Lorraine Lombardi's slides showing the interplay between the sixth nerve nucleus on one side and the medial rectus subnucleus of the third nerve nuclear complex on the opposite side, and how these guys are tied together by the medial longitudinal fasciculus. If you have a lesion of the medial longitudinal fasciculus, that's going to result in a discommunication between the sixth nerve nucleus on one side and the medial rectus subnucleus of the third nerve on the opposite side. And essentially, that's what produces the adduction deficit in the setting of an intranuclear ophthalmic lesion. Now, you can affect one MLF tract that produces an intranuclear ophthalmic lesion or a monocular intranuclear ophthalmic lesion, or you can involve both medial longitudinal fasciculi, and that produces a bilateral intranuclear ophthalmic lesion. Both of these being very common with multiple sclerosis. So let's talk about an intranuclear ophthalmic lesion. There's an ipsilateral lesion of one MLF that results in an ipsilateral adduction deficit. The fellow eye, as it's turns out normally, but about 2/3 of the time they will have some abducting nystagmus. I'm going to show you that in just a moment. If they can converge, meaning that they can turn their eyes in and overcome that adduction deficit, that puts, if it's spared, that typically puts the lesion lower in the brainstem, usually within the pons. But if convergence is abolished, that puts it higher, typically within the rostral midbrain. Now, this is a 26-year-old woman with an internuclear ophthalmoplegia due to multiple sclerosis. What I want you to pay attention to in the video are several things. A left adduction deficit when she looks to the right. She's going to have some right abducting nystagmus. And she's got a skew deviation. That's a vertical misalignment between the two eyes, which is beyond the scope of this lecture. And she's got, her convergence is somewhat spared. So here you can see that there she is looking to the right, right eye turns out, left eye does not turn in well, and she's got a little bit of abducting nystagmus on the left side when she looks to the right. There again, looking to the right, right eye turns out, left eye does not turn in. That's her adduction deficit on the left. That is the side of her MLF lesion. And she's got a little bit of a vertical misalignment between the two eyes. That's her skew deviation. And when she looks at a near target, she can turn that eye in just a little bit better. That is noted on her adduction deficit. Now, I'm going to skip over that. Let's look at her brain. What you can see here is on this T2 weighted image, at the junction between the midbrain and the pons, I've pointed to you with this arrow, this hyperintense lesion involving the medial longitudinal fasciculus on the left side of her brain. This is her demyelinating plaque responsible for her intranuclear ophthalmic lesion. So this is her multiple sclerosis attacking these white matter pathways on the left side of the brainstem, producing her left intranuclear ophthalmic lesion. Now, what if you involve both right and left MLFs? Well, that produces a bilateral intranuclear ophthalmic lesion. And these individuals have bilateral adduction deficits. Oftentimes, the abducting eye will have some evidence of abducting nystagmus. And once again, testing for convergence, if it's spared, that's probably a lower lesion, such as in the pons. If it's abolished, that's going to put it higher, typically within the midbrain. So here's a 36-year-old man with relapsing remitting multiple sclerosis. What you're going to see on his video are bilateral adduction deficits with contralateral abducting nystagmus. So there's the video. You can see looking to the right eye turns out, a little bit of an adduction deficit on the left. And when he looks to the left, it reverses. Left eye turns out, right eye has difficulty turning in, and he's got some abducting nystagmus on the left. So there's his adduction deficit on the left side on right gaze. There's his adduction deficit on the right side on attempted left gaze, and his abducting nystagmus.
Hey, Len, as you're going through these videos, and I've listened to both you and Joe over the years being, I guess, neuro gods out there, and certainly have made my comfort level in the office better. Joe, is this where you talk about, you say it with me, there's no medial rectus? Is this where you apply this that's out there because there's no medial rectus palsy?
Yes, I do say that quite a bit. People think that if there's an adduction deficit and nothing else, superior rectus, inferior oblique, inferior rectus, they call it a partial third nerve palsy, and it really isn't. I don't subscribe to medial rectal palsies. It's either entrapment thyroid, neuromuscular junction disease, myasthenia gravis, or it's an internuclear ophthalmoplegia. So I kind of have to find it. What is your thought there, Len?
100%, Joe. And yeah, you bring up such an excellent point, because so many of these individuals get referred to us with exactly what you call, what you alluded to earlier, a partial third nerve pulse. The difference is it's purely an adduction deficit. They don't have the ptosis, and the other recti muscles are entirely normal. Could not agree with you more.
Len, I got a question. When we have, well, we know about the optic neuritis, but when you have an internuclear ophthalmoplegia that is demyelinating in nature, what is your time frame for recovery?
Yeah, that's a really great point, Joe. In that most of these individuals will get better regardless of treatment. And if they are going to get better, I usually expect them to be getting better at about the same rate as individuals with demyelinating optic neuritis, meaning that over a period of about 1 to 3 months, if it's going to get better, it is. If they're pulsed with IV steroids up front, it's going to be getting better quicker. But the interesting thing about internuclear ophthalmoplegias that I have found over the years is that recovery is much less predictable than that with optic neuritis.
Interestingly, I had a case probably a couple months ago now. I think he is a fellow probably in his 80s, and he had double vision. He had a pure adduction deficit in his left eye. And I did something that I always caution other people not to do, and that was talk yourself into something. And I kind of talked myself, and there might have been a little bit of abducting nystagmus. I made my diagnosis of an INO, and I got the imaging expecting to see probably an infarct, and the brain came back perfectly normal, and he resolved within a week.
Yeah.
So at that point, I started going down the other pathway, that this was a pseudo-INO and myasthenia gravis. One of his antibodies, I think binding was close to abnormal, but was normal. So I just think he's a seronegative. But a week, improve in a week, that to me that's not infarctive.
Yeah, I agree with you. The interesting thing also about these cases is that, the beautiful thing about the internuclear ophthalmoplegia is you know exactly where to direct the scan. You know what side of the brain, what level of the brain, but yet there are those cases that come back and you just don't see anything. Is that because we're missing it? The cuts are the cuts are just going above and below. I don't have a good answer for you. Or, as you just said, maybe it's something else altogether.
Mm-hmm.
Yeah. Well, fortunately, in this case, we have neuroradiologic confirmation. This is a T2-weighted image. And what I'm pointing to here with the arrow is that area of hyperintensity on either side of the Sylvian aqueduct, which is where the right and left medial longitudinal fasciculi are running. And this is a demyelinating event that is involving both right and left MLFs. Now, there's a variant of a bilateral internuclear ophthalmoplegia called a wall-eyed bilateral internuclear ophthalmoplegia. Perhaps the more appropriate or less pejorative term for this is an exotropic bilateral internuclear ophthalmoplegia. So these individuals produce with three cardinal findings. One is a bilateral internuclear ophthalmoplegia. Two is a very pronounced exotropia. And third is an abolished level, is they cannot converge. And that is because these lesions always occur very, very high within the brainstem, typically high midbrain. So here's a woman who I saw about a year ago, who presents with double vision in both primary gaze as well as looking both right and to the left. She's got a 10-year history of relapsing remitting MS. She's taking monthly injections of Kesimpta. Her visual acuities are near normal, 20/25 in the right, 20/30 in the left. But let's take a look at her videos.
Here again at my.
And I apologize for the sound.
Yeah, I'm going to move you over here. Good. Back. And we'll go over this way. A little bit of a skew. It's coming out more in right gaze. Okay. And then look up high. And look down. And right here again, just to the left. And to the right. Okay, all done.
Hey,
Okay,
Len, I have a question for you.
sure.
So you kind of answered it in your last statement that you said this lady's been battling MS for a few years, kind of going off and on. Will these INOs will they present as the initial finding, or is it usually that they have the MS and then these are later findings?
Yeah, that's a great point, Greg. And the answer, as you've alluded to, can be both. I don't know. I don't have the exact statistics. It is more likely that these individuals come in with an established history of MS. But I can tell you from personal experience, for whatever reason, I've seen quite a number of these cases over the years where this is their initial presentation of their MS.
Thank you.
So you can see from the videotape the pronounced exotropia and then the superimposed bilateral internuclear ophthalmoplegia, and this woman cannot converge.
Here again.
Oops. So looking at her brain, now the beauty of this is that we know, as Joe alluded to before, you know based upon the clinical findings exactly where you want to direct this scan, and that is looking at both MLFs at the level of the midbrain. And that's exactly what you can see here on a flare image on the left, T2-weighted flare on the right. But what I'm pointing to here, and it's always helpful when they come in, you're reading the MRI and they've got arrows that are pointing to the lesion. That's exactly what you can see here. You can see that there's this hyperintensity here on the flare, here on the T2, that is lighting up both right and left MLF. So that is this woman's multiple sclerosis attacking her MLFs, both sides. I want to talk now about something called a 1 1/2 syndrome. And a 1 1/2 syndrome is a lesion, in this case, a demyelinating lesion that involves the sixth nerve nucleus and the subnuclei of what's called the paramedian pontine reticular formation on one side, but then also the ipsilateral medial longitudinal fasciculus. It is practically impossible to put a lesion in the brain that only involves the sixth nerve nucleus and does not pick off the MLF. So what happens is that when these individuals, when they look to the side of the the pathology, nothing happens. On the affected side, the affected eye doesn't turn out, the other eye doesn't turn in. But when they look opposite the side of the pathology, the contralateral eye will abduct normally, but the ipsilateral eye will not come in any further than the midline or close to it. So the 1 is the gaze palsy, the 1/2 is the internuclear ophthalmoplegia. And that is termed a 1 1/2 syndrome. So here's a young woman, and this is a case where this was the first presenting sign of her multiple sclerosis. And what I want you to pay attention to is that when she tries to look to the right, it's really hard for her to turn the right eye out or the left eye in. That's her 1, that's her gaze palsy. But when she looks to the left, you're going to see that the left eye turns out, but the right eye is going to have a little bit of an adduction deficit. That's her internuclear ophthalmoplegia, or the 1/2 part of the equation. So let's take a look. So here she is trying to look to the right, and she really can't turn the right eye out very well, can't turn the left eye in. And looking to the left, she's got a little bit of an adduction deficit on the right side, and she's got a little bit of abducting nystagmus on the left. Now, when we missed it there, it's pretty, oftentimes you're going to see a little bit of vertical nystagmus when you take these people into upgaze, but they're looking to the left. There's her adduction deficit on the right and her abducting nystagmus on the left. And when we try to get her to look to the right, it's very difficult for her. She can't do it. So that's her 1 1/2 syndrome. Great. So what's the value of this? It allows us to be very, very specific with our MRI instructions. We're looking at the right side of the brain, at the level of the caudal pons, at the level of the sixth nerve nucleus. So on FLAIR imaging, what you can see, lower pons at the level of the sixth nerve nucleus, there is this area of hyperintensity. That is her demyelinating event. And on T1 weighted imaging with gadolinium, we can see that it's showing a little bit of enhancement. That tells us that this is fairly recent, that it's been there probably been there less than a month. So that's her 1 1/2 syndrome. Now, the rest of her brain looks like this: multiple high signal lesions, paraventricular in location. Some of them are enhancing, some of them are not. By definition, all of this meets the criteria for multiple sclerosis. So this woman was pulsed with IV steroids. She comes back to see about a month later, and her double vision is gone. And we can see that her motility pattern has improved to normal.
Hey, Len, a question came in, and I'm anxious to hear what you have to say. Is there an ICD-10 code for the 1 1/2 syndrome?
Yeah, boy, that's a great question.
I think they're because I had to dig this out. They're all going to fall under INO, Webino, 1 1/2. It's all going to fall under brainstem syndrome.
Yeah.
Just look for that.
I'm going to trust you on that one, Joe. You come as close as you can. Great point. Great point.
And you could probably use multiple sclerosis as the ICD-10 too.
We use that a lot too. Sometimes they will fight you on it because you're specifically commenting on an eye finding. But I agree. I think that the insurers are becoming a bit more benevolent. There is a variant of the 1 1/2 syndrome called paralytic pontine exotropia. And what that means is that the eye with the adduction deficit is going, what you have is that the eye with the internuclear ophthalmoplegia is going to appear exotropic. And the thought on this is that you have a PPRF, or a lateral gaze center, on one side that is essentially normal, and it's pulling the eye in the direction of the normal PPRF. So you get an exodeviation on the side of the internuclear ophthalmoplegia. So this is a case of a woman with paralytic pontine exotropia that has a combined 1 1/2 syndrome, along with an exotropia of her left eye. So what you can see is that in primary gaze, she's got an exodeviation on the left side. But the interesting thing is that going back in her history, she previously presented to our clinic with evidence of a left esotropia. So either there was an error in the record keeping, or her ESO has now gone to an exo. But what I want you to pay attention to is that she's going to have a gaze palsy when she looks to the right, and she's got an internuclear ophthalmoplegia when she looks to the left. So here we go.
Okay.
So there's her gaze palsy looking to the right, and there's her internuclear ophthalmoplegia on the right side when looking to the left. Let's take a look at that one more time. And you know what, before I say that, I realized I'm going to have to correct a statement that I made before. The internuclear ophthalmoplegia, the exodeviation, is across from the side of the internuclear ophthalmoplegia. So here we go.
Okay.
There's her gaze palsy to the right, and there's her right internuclear ophthalmoplegia when she looks to the left. Okay, so once again, highly localizing value. We know that there must be pathology on the right side of the brain at the level of the caudal pons, involving both the right sixth nerve nucleus as well as the right medial longitudinal fasciculus. And indeed, that's exactly what you can see here. This is a T2 weighted image. You can see the hyperintensity at the level of the caudal pons, involving both the right sixth nerve nucleus as well as the adjacent medial longitudinal fasciculus. And you say to yourself, how do you know that you're at the level of the caudal pons? Well, we look for these two little bumps. They're protruding into the lateral ventricle. Those are the facial colliculi. And that's literally where the seventh nerve fascicle is wrapping itself around the sixth nerve nucleus as it's now coursing through the brainstem to get into the prepontine cistern. But when you see those two little bumps, that tells you that you're at the level of the sixth nerve nucleus. Now, that was this woman's presentation of her, that was her initial presentation of her multiple sclerosis. She was pulsed with IV steroids. She comes back to see you a couple of months later, and look at what's happened. Now she has resorted back to her left esotropia, and otherwise a pretty normal motility pattern. So let's take a look. So there she is looking to the right. There she is looking to the left. So essentially her 1 1/2 syndrome is resolved, and she's back to where she was prior to her demyelinating event, which is a left esotropia. All right, that's called paralytic pontine exotropia, variant of a 1 1/2 syndrome. So we're ready for our next polling question. What is the anatomical location of a lesion in a patient with a bilateral internuclear ophthalmoplegias? Right MLF, left MLF, or both right and left MLF tracts?
And Len, you're caught up on all the questions. The last one was about the ICD-10 code. But I think what you do is type into your system brainstem, and that will come up.
Great.
And I think just to clarify, you really got a lot of exact anatomy here. And we don't want to overwhelm our audience. Everybody who's listening is going to pick up pearls. And when they see a patient like this, we're not necessarily advocating you get the imaging yourself. But if they're going to be seeing other doctors, ER physicians, it is our obligation to give them guidance. And that's really where this type of talk is going to help everybody.
Absolutely. Okay, well, overwhelmingly, we've jumped on the right answer, both right and left MLF pathways. Okay, let's move on now and talk about our final motility problem that we typically see in people with multiple sclerosis, and that is nystagmus. Now, nystagmus, statistically, very, very common with multiple sclerosis, either as a presenting sign or at some point during the course of the disease in about 30% of individuals with MS. There are various types of nystagmus that can present with multiple sclerosis. By far, the most common is what I've listed for you here, which is gaze-evoked, also known as gaze-paretic nystagmus. Now, this is another one of Dr. Lombardi's slides, once again showing the bilateral MLF pathways, but also showing at the level of the caudal pons, an area called the nucleus prepositus hypoglossi, which connects with the medial vestibular nucleus, also on the same side. And those two guys together form what is called the neural integrator. Now you say to yourself, well, what in the world is a neural integrator? Neural integrator is responsible for holding gaze position. So in other words, if I look hard to the right, the neural integrator on the right side is going to effectively hold my gaze to the right. If it's defective, the eye is going to tonically deviate a bit more toward primary gaze, and then boom, it's going to catch up back into the direction of the leaky neural integrator. So in other words, the fast phase of the nystagmus is toward the side of the pathology. Now, gaze-paretic nystagmus, once again, is due to a lesion of the nucleus prepositus hypoglossi medial vestibular nucleus combination. But I would caution you, while it's very, very common to find the pathology in the brainstem among individuals with the internuclear ophthalmoplegias, it's not as common to find similar pathology on imaging within this part of the brain in the setting of nystagmus. But it doesn't really matter. And the reason it doesn't really matter is because if this is due to demyelinating disease, if it's due to multiple sclerosis, they're going to show other evidence vis-a-vis hyperintensities involving the paraventricular white matter tracts within the brain, as I described for you before. Now, you can see this with multiple sclerosis, but this is commonly associated with other forms of CNS depression, notably ethanol, which is why police officers are trained to test for this, as well as other CNS depressants. But what I want to show you here, and this gets back to some of what we described before, and I'm not even going to get to her underlying diagnosis. All I'm going to say is that this is a 71-year-old woman who presents with acute oscillopsia and vestibular dysfunction in the setting of gaze-evoked nystagmus. So let's take a look at her motility findings.
Just keep looking here.
So there you can see, looking to the left, she's got this left beat nystagmus. Looking to the left, there's her left beat nystagmus.
We're going to take you to the other side now. We'll go this way.
And when she looks to the right, she now has a right beat nystagmus. but it's a little asymmetric between the two eyes, and this woman is symptomatic. This is not physiologic imposition. This woman, and this is the kicker. See, looking up, she's got a little bit of vertical nystagmus. That's very, very common with gaze paretic nystagmus. Now, 71-year-old woman, diabetes, hypertension. I go back to the case that Dr. Salka mentioned earlier of an individual with a weak medial rectus muscle. What is this? Well, I will tell you that when I saw this woman initially, I was absolutely convinced that this was a brainstem infarct responsible for her gaze paretic nystagmus, as well as her oscillopsia, as well as her vestibular dysfunction. And I was wrong. This is her brain. These are axial cuts taken just a little bit above the lateral ventricles. And what I want to call your attention to is here on the right side of her brain. On FLAIR imaging, you can see these multiple high signal lesions. A big one here adjacent to the lateral ventricles, a smaller one here that is subcortical. But then looking at the same level on T1 weighted imaging on the left, you can see that there's a little bit of residual enhancement. Now, stroke does not enhance. MS does. This happens to be this happens to be late onset multiple sclerosis. So it just goes to show you, we think about this disease as typically falling within between 20 and 40 years of age, but you can get it in kids. And as I'm showing you in this case, you can get it in elderly individuals as well. And looking at the rest of her brain, here you can see that she's got multiple high signal lesions showing up within her cerebellum. That's her vestibulopathy. So late onset multiple sclerosis presenting as gaze paretic nystagmus in a 71-year-old individual. One of the other things that you look for, that I like to look for in an individual with gaze evoked nystagmus, to check myself, I look for the vertical nystagmus and upgaze. The other thing that I look for is the presence of a rebound. And by that, what I mean is that you take them from extreme gaze, where you get that high amplitude, low frequency nystagmus, and then you bring them back to primary gaze, and you look for the eyes to beat a couple of times in the opposite direction. If they do, that's called rebound and is highly pathognomonic of gaze paretic nystagmus. So here's a gentleman. What you're going to see is that he's got gaze paretic nystagmus looking both right and left. And when we bring him back to primary, it's going to beat a couple of times in the opposite direction. That's his rebound. So here we go. So there he is looking to the left, and there's his left beat gaze paretic nystagmus. And we bring him back to primary. If you look real carefully, he beats just a few times in the opposite direction, but you're going to see it better when we take him to the right and then take him back to center. So there he is looking to the right. There's his right beat nystagmus. And watch what happens when we take him back to primary. So there you can see him beaten a few times in the opposite direction. That's abnormal. That's the rebound component of his gaze paretic nystagmus. And you can see he's got a little bit of vertical nystagmus whenever we ask him to look up. And that's never normal. All right, so to our next polling question, what is the percentage of MS patients who will present with nystagmus? A, 10%, B, 20%, C, 30%, D, 40%. Now, while we're answering that question, I just want to take a couple of minutes to go back to something that I mentioned before, which is differentiating gaze paretic nystagmus from physiologic end position nystagmus. Number one, people with physiologic end position nystagmus are never symptomatic. It's just the eye's inability to overcome the viscoelastic forces within the orbit, but they're never symptomatic. Two is that when you bring them back to primary gaze, you never get a rebound. And three, when you ask them to look up, you're never going to see vertical nystagmus.
I think you're all set on questions, Len. You're doing great.
Okay, great. Well, yeah, the majority of you got it right. About 30% are going to, or you're going to have nystagmus, and I think it was partially my problem. I said presenting sign. I think I went back and forth between presenting sign and having it at some course during the disease process. I think the important thing to remember is that gaze paretic and multiple sclerosis are very, very, very oftentimes linked.
So let me ask this question here, Joe, and it kind of circles back to, there's a lot of great information. There's a lot of clinicians here. Joe and Len, you guys, do this, in your sleep, for lack of a better term. Patient walks in and they have, an INO. And, what's the urgency that I have? Joe mentioned, working with the, physicians or the ER to get an image. Help me out with my urgency here.
You want me to?
Yeah, go ahead, Len.
Absolutely.
I don't consider these an emergency. I like to get an image within about a week. Typically, what I will do is I'll get their imaging done within the next week, or within a week, and then I'll see them a week later to review their images. What do you think, Joe?
I agree, and I have my expectations. If it's a young person, I think it's going to be demyelinating, and I tell the radiologist that to specifically look for that. If it's older, I think it's going to be infarctive, and I tell the radiologist to look for that. And based upon that, the patient's going to end up with neurologist skilled in demyelinating disease, or a stroke neurologist, depending on what the etiology was. But I agree. It is not an emergency.
So let me throw this out as one more question, just as how they're going to present. Patient has MS. We kind of know that as a history. You mentioned that a couple times. Double vision. It's sudden onset with these, or they kind of slowly come on. And obviously they come in. I'm going to go with the old. No one can have a medial rectus palsy. So it's kind of helping me out with thinking what's going on here. But are they like, hey man, this slowly came on, or this was like, wow, now I'm seeing double?
Yeah, it's the latter. It's right away.
Agreed.
So they'll be in pretty quickly, calling the office.
Mm-hmm.
Yep.
Okay. All right. Perfect. Thank you.
Great. Well, we're in the home stretch now, and want to talk a little bit about ocular biomarkers for multiple sclerosis. I said that currently there is no pure ocular domain as it relates to the McDonald criteria for MS, but hopefully we're moving in that direction. And I want to talk about OCT, both in the setting of optic neuritis as well as just patients that have MS, no prior optic neuritis. Now, when you see an individual with optic neuritis, I alluded to this earlier, is that up front, what we oftentimes see is that the nerve fiber layer is going to be somewhat edematous. You're going to see that thickening. You're going to see some thickening to the nerve fiber layer, even with retrobulbar optic neuritis in the acute setting. And acutely, you're going to have a pretty normal appearance to the ganglion cell layer, ganglion cell complex. But pretty quickly, over a period of several months, the nerve fiber layer is going to thin down considerably, and oftentimes more so involving the temporal sector. And then you're going to see diffuse thinning of the ganglion cell layer or ganglion cell complex, depending upon what platform you happen to be using. So you literally get this with optic neuritis, something of a paradoxical response, in that as their vision is getting better, their nerve fiber layer and their ganglion cell layer or complex is thinning down. Now that's with optic neuritis, and that pronounced thinning on the OCT, you're going to be seeing it significantly within 3 months. Now, what about MS? It is very, very common to see thinning of both the retinal nerve fiber layer as well as the ganglion cell layer in the setting of MS in the absence of optic neuritis. It won't be as dramatic as what you see with optic neuritis. It won't be as frequent as what you see with optic neuritis either, but in a very, very high percentage of these individuals, it's going to be there. And not only that, but it's well linked to other vision or visual motor biomarkers, such as OCT thinning linked to the disease burden load that is evident on MRI, as well as abnormalities with low contrast letter acuity, and to a certain extent, certain types of eye movements. But what I want to focus on is, let's take a look at 2 cases. Here's a 31-year-old woman, 10-year history of relapsing MS. She's on infusion therapy with ocrelizumab, is doing well. She had optic neuritis in her right eye with good recovery of vision several years prior to my seeing her. Her visual acuity is 20/20 in the right eye, 20/20 minus in the right eye, 20/20 in the left eye, little desaturation of color in the right eye. Looking at her optic nerves, what you can see is that in the right eye, it's got some temporal pallor, which is typical. You're always going to see that in people following their optic neuritis. And in the left eye, we see what looks like a pretty normal appearance to her optic nerve. Now, these are her nerve fiber layers, right eye above, left eye below. What you can see predictably in the right eye is that she's got this temporal wedge of nerve fiber layer thinning. But in the left eye, where she has not suffered optic neuritis, she also has a little bit of thinning to the temporal peripapillary retinal nerve fiber layer. And this is very common. It's very, very common for individuals with multiple sclerosis without a prior history of optic neuritis to have some thinning of the retinal nerve fiber layer, and specifically involving the temporal quadrant. Here's a case of a 30-year-old woman. 1-year history of relapsing MS. This woman is also on infusion therapy with ocrelizumab and is doing well. No prior history of optic neuritis. Visual acuities are normal, 20/20 in each eye. And you'll look at her OCTs, and specifically we're looking at her nerve fiber layers here, but what you can see is that she's got a little subclinical thinning of the temporal tissue in both eyes. And as I already alluded to, this is very, very common in the setting of multiple sclerosis, even in the absence of optic neuritis. Now, this is significant only from the standpoint that it is commonplace with multiple sclerosis. It's not so important that we see it. It's more what is happening over time, because this is the beauty of sequential OCT testing among your patients with multiple sclerosis. And that's why you're going to be seeing many, many more of these individuals that are sent to you from neurology, specifically with the request, do an OCT and send me a report. Because the question is, A, is there an abnormality noted on the OCT, particularly within the nerve fiber layer, but we're also seeing this within the ganglion cell layer. But more importantly, is it progressing? Is it getting worse over time? So, final point on that is that OCT is quickly becoming mainstay as a biomarker of disease activity in the setting of multiple sclerosis. And specifically, what we're looking for is progression. If I have an individual that has MS, I will test them on an annual basis. And specifically what I'm looking for is progression. But it's very, very important that you're not just testing them, but you're sending that report back to neurology. So here's our final polling question. Which sector of the peripapillary retinal nerve fiber layer is thin in an individual with MS? Superior, inferior, nasal, or temporal?
And Len, while that's coming in, we'll give them a minute. A really good clinical question came in. Have you seen late onset, 60 and above, NMO and or MOGAD?
Yeah, that's a really good question. The answer to you is right now, as it relates to NMO, absolutely. NMO presents later than MOGAD. I cannot recall a case of MOGAD presenting in an individual over the age of 60, but it can happen. I think that the issue is very simply that MOGAD is the new guy on the block. If we were having this discussion 10 years ago, we wouldn't be talking about MOGAD because the entity simply wasn't there. A lot of those individuals, as I mentioned before, were lumped into the category of CRION, chronic relapsing inflammatory optic neuropathy. And we now know that overwhelmingly, those were individuals with MOGAD. So just because I haven't personally seen it, it's out there. I think it's just a matter of time until it's reported on with greater frequency.
Yeah, I would just add in there to the person asked David the question. Remember that MOGAD and NMO are only about 10% of all optic neuritises combined. When you're in that kind of age range, don't forget the usual suspect, the ischemic neuropathies, particularly temporal giant cell arteritis.
Yeah. And I will tell you, getting back to that last question, which is excellent, not too terribly long ago, I did have a woman who presented with a little bit of reduced vision. It had been that way for quite a while. Joe, I know, I completely ascribe to your philosophy, and that, if they tell you that it's been going on for several months, it no longer falls into that category of something that requires urgency of investigation. I did image her. She had multiple high signal lesions within her brain that were consistent with small vessel disease. Nothing new there. We see that all the time. She had diabetes, had hypertension. But along with that, I did test her for both NMO and MOGAD, and she did come back positive for MOGAD. So it's out there.
Mm-hmm.
So Len, on that last question here, where everyone, 81% got it right, says which sector of the peripapillary retinal nerve fiber layer is most prone? Is that the maculopapular bundles being affected?
Yeah, absolutely.
Yeah, is there any correlation there with that? I'm just trying to think it out. I just
it's interesting if you look at the OCT testing, and you even go before OCT testing, and you go back, geez, close to 20 years now. I remember when Laura Balser first started reporting on using low contrast letter acuity as an indicator, as a surrogate biomarker of disease activity with multiple sclerosis. Her point was rather simple and straightforward. Her point was, look, we look at these demyelinating plaques that occur within the brain of individuals with MS, but that's just what we can see. We know that MS is a disease that affects all of the brain. It's just that there are some areas that are showing up more distinctly within on neuroimaging. But so too, just as since MS is a global disease of the central nervous system, we ought to be able to detect this using perhaps more sophisticated ways of vision testing. That's what led to this whole, over 20 years ago, looking at low contrast letter acuity, or what we used to call contrast sensitivity. So you think about it, well, where are individuals going to show abnormalities most if there is reduced low contrast letter acuity? Well, that's largely a function of macular integrity and the papillomacular bundle fibers. It's just now that we're catching up, being able to identify that structurally with the OCT.
Yeah. Well, we always say, the eye is brain, and here you are. This is exactly it. I want to have you quit sharing your screen there, if you would, my friend, unless you have another slide.
Nope,
I think there's one more.
that is it. We've gone over the key points, the diagnostic criteria, the pathogenesis and clinical manifestations, afferent, efferent system, and then finally talking a little bit about visual biomarkers, notably OCT. And with that, I'm going to stop sharing my screen.
And I'm going to share mine and say, thank you for doing this for us. Let me move a couple things out of the way here. I really enjoyed, because there's a lot of double vision. There's a lot of, neuro when you do neuro lectures. And I really enjoyed that you kind of just narrowed it down to just multiple sclerosis and just kind of talked about it at a very granular level. So from my standpoint, it was very enjoyable. I'm sure you're getting your round of applause out there, your virtual round of applause. So, Joe, any comments?
I thought it was an epic presentation. You really covered a lot of information, a lot of neuroanatomy. And I think the audience is going to be really helped out. It was an unusually silent audience. I think that they were just taken with every word and didn't want to be distracted by typing out questions. But it was a fabulous presentation, Len.
Well, thanks for the opportunity, folks.
Thank you.
And Len, if you look at the into the chat box, if you click on it, if you have access to that, you'll see your virtual round of applause coming through. Loving the video, saying thank you. So again, thank you.